Earlier this week, Gabriel Cousins was here, and he follows a whole food plant-based diet, mostly a raw whole food plant-based diet, and he agrees with the things that you say in general. One thing he did say that is an outlier from what I normally hear is he was saying that he thinks the average the best cholesterol would be like 159, and that low cholesterols sometimes are associated with depression, and he says that there's not really, and he's completely against eating animal products, but he says among people who are eating plant-based diets that it's better if your cholesterol is a little bit higher. Do you want to comment on cholesterol levels and what they should be, and assuming we're eating a plant-based diet, if it matters? Any thoughts on that?
Well, I'll start, and then we'll go down. Well, the first thing is that association's not cause and effect relationship. So I use your lines all the time, Dr. Campbell, about phone poles and heart disease and driver's licenses and breast cancer. You know, in countries where there are more phone poles, you have more heart attacks. Well, that doesn't mean phone poles cause heart attacks, right? So the people cite these associations all the time and infer a cause and effect relationship, and that's how bad ideas catch on and become pretty entrenched. Depression, by the way, is not caused by low cholesterol. It's a thinking disorder. And your cholesterol level doesn't affect how you think. That's to be worked out with a psychologist. Furthermore, I think where a lot of this low cholesterol is bad for you came from is studies showing that people with low cholesterol, people diagnosed with cancer had low cholesterol, but we now have a pretty good amount of evidence. I wrote a paper on this that I was able to find 7 or 8 studies supporting it, that when cells become cancerous, they start eating cholesterol. Plasma cholesterol becomes an alternative fuel. And so by the time the cancer is diagnosable, cholesterol levels are very low. So what you have is an association, but it's the opposite. It's not that the low cholesterol causes cancer, it's the cancer causes the very low cholesterol at the time of diagnosis. So I think that there's a problem in jumping to the cause and effect relationship from an association. So I think, having said that, I think ideal cholesterol levels, lower the better. I said this afternoon, my father's IQ is higher than his cholesterol. That's the way we like to keep it. 150 total cholesterol, 80 lower, 80 for LDL. I subscribe to Dr. Esselstyn's recommendations on that, and that's what we strive to do in our office.
So, that was great answer. So from the cardiology point of view, we've had a little bit of whiplash here. We were doing that $30 billion statin because people talk about their side effects, and I usually tease that the biggest side effect of statins is breaking the Medicare trust fund because people aren't dead. They actually do work. They should be unnecessary, but they do work. Now, the issue that we were concerned about is that if you got and this was just, I'd say, 3 or 4 years ago, if you got the LDL cholesterol, and we'll talk about LDL because when you talk about the total, that would include the good cholesterol, and some people are genetically pre-programmed to have a high cholesterol because their good cholesterol is really high, and then the only way to really talk about their risk is to talk about the bad stuff, the LDL, the stuff that plugs up arteries. So we thought that if your LDL cholesterol got below 25, your brain would fall apart or something like that. And this was just accepted jargon. Then there was the Dallas Heart Study, and they saw some people, some very few people who had extremely low LDL cholesterol, 7, 14. I said, well, we've got to find out, what are they doing? Are they in mental institutions? No, one's an aerobics instructor, one's a business person. They're normal human beings, and they have no heart disease in their families. So they run the genome, and they find out that they're missing, and this is probably one of just a few such things, but the one that became famous about this story was called PCSK9. How many of you have heard of that? Just a handful, okay. So PCSK9 is a molecule that's responsible for telling your LDL receptors in your liver, it's time for you to quit, you've been out here too long, it's time, we're gonna involute you, you're gonna go inside the liver, you're not gonna work anymore. If your PCSK9 is not working, your LDL receptors just keep going, Energizer bunny type stuff. And they pull the cholesterol out of the bloodstream, and your LDL gets extremely low. And it protects your heart and your blood vessels. So it turns out that big industry got wind of this, and they came up with injectable antibodies. For $14,000 a year, you too can get injected twice a month. and your cholesterol will fall incredibly well. And so, vegan diet is a wonderful way. High-dose statin is a great way getting your cholesterol down, but PCSK9 inhibitors are just absolutely fantastic. I do have one patient who's doing all three. His LDL is 3.5. Okay, and so it's, and he's doing fine. And so the question is, why would you want it to ever be that low? Okay, so just last two things on it. One is that in development, the babies who are trying to do brain growth and body growth, their LDLs are single digits, and then they get double digits, and then they grow as you start feeding them more animal stuff. So we're not genetically pre-programmed to have these high cholesterols. Number two is that if you look at the PCSK9 research, which is getting more and more extensive, one of them called the Glagoff trial, who was named after Seymour Glagoff, my mentor at University of Chicago, who spent all of his career looking at plaque morphology, plaque in arteries, showing that, I'm not going to ask how many people have had an angiogram and been told, oh, you've got a 10% narrowing, you're fine. Well, no, the Glagoff hypothesis is that you actually get remodeling outward when you put plaque in your arteries. It grows and grows and grows, and it's only when you have so much plaque in there that it can't grow anymore, then it starts to narrow. So by the time you have a 10% narrowing, you have a massive plaque burden. Okay, so that's what he's famous for. And so it's nice to name a trial after him that looked at how what happens to plaque over time. Now, it wasn't as impressive as what you see with Dr. Esselstyn, but they had a good large population. They could actually make a line. And it turns out for 100% of people to have plaque going away, you need an LDL less than 58, which is close to what we were thinking, it's 70, it's 60, something like that. But the interesting part, defending the idea that as low as possible, is that that line keeps going down. The lower it is, the more plaque regression you get. And so, for you're treating a coronary disease, carotid disease, peripheral artery disease population, getting the cholesterol down and keeping it low is a really good idea.
Okay. Not being a clinician like my colleagues here, my introduction to the cholesterol world to a great extent was in our China study, which was analyzed chemically, at least in a laboratory, about 1990, so what is that, a quarter of a century ago already. At that time, we wanted to analyze cholesterol, of course. There was a general idea that any cholesterol level below 150 was bad. It was said that suicides are higher. Colon cancer, there was a couple of studies indicating that was possibly higher. And some of that was what Dr. Popper just referred to, the result of the cholesterol going down once diagnosed. But in any case, that was the scenery at the time, the discussion. And so we got cholesterol levels in China, average 127. 127. Bill Castelli was a friend of mine. He's the one who directed the Framingham Heart Study at that time. And even Bill found it really rather remarkable we should have such low levels, but he allowed for it because he thought that might be real. But in any case, the feedback I got at the time from some of my colleagues, you're crazy. The Chinese that can't be true. And so, my being skeptical myself, to some extent, we went back and analyzed it by two more methods and two more different laboratories, and essentially got the same results. So all of a sudden, here we had an average, 127, and a range of means for the counties ranged from 88 total cholesterol to a high of 170. So we were in a new territory. And when we started looking at what kind of disease rates change throughout that region, it's very clear. Western type of diseases, I mentioned today one of the slides, Western diseases just gradually, as our group came down, the lower and lower the cholesterol. And I know, of course, we get into LDL, HDL discussions, big particles, little particles, all that sort of stuff. And I also have to say, I don't see cholesterol as being, from my definition, as a cause, quite frankly, of disease. It's a really good, on a population-based studies, it's a very good indicator of disease risk, including not just heart disease, but also cancer and some other things. And so I don't know, I think the cholesterol, I think we're getting too much into the weeds, talking about cholesterol in too much detail, because there's one more factor to consider, and that is that we know of people with high cholesterol levels who don't have heart disease, And some people with cholesterol levels, low levels, they do have heart disease. You had that with Joe Crow, your friend. And so we get ranges. And sometimes we worry, I suppose, on an individual level, whether it's good or bad, if we have a 210 or 220, or maybe that's too high. Even 180 is too high for a lot of people. I see it too, in that sense. Cholesterol is just one indicator. It's a good indicator. It's a good indicator for overall diet and disease risk. But I think, yeah, I mean, that's all I can say. It's really, it's that general trend that's so clear. If you look at Western populations at the time we did, starting out from around 300 down to 200, that was the range considered normal in those days. We saw a decrease in heart disease risk, Mr. Fitzgerald and others. But we continued that same range, previously not having an opportunity to see it, going from 170 all the way down to 88. And we saw this remarkable correlation, really highly significant, with Western diseases in China, which weren't all that common. But we saw the same relationship. And so I became really impressed with the idea that cholesterol, we don't necessarily get danger zones when we're down below 150 at the time. Maybe, I guess we can make some cases, but cholesterol levels too, we know lots of things. But one thing it does have to do with, I'm really convinced, is whether or not we were nursed when we were young. And whether that in turn left an imprint. We published that work in Science, and I'm not sure we talked about that. But incidentally, Dr. Williams, I have a question. If I'm not mistaken, did you say that you said something like statins work? And so I was just talking today, I have to make a comment on this because I offered the possibility that from my analysis of the literature, as I say, not being a cardiologist, that deaths, coronary deaths, are not really lowered to any significant extent by statins. The best I could find was about a 9% reduction in deaths. And sure, it's true. Statins, lower cholesterol, I agree with you. But whether that translates into lower mortality rates, if you will. Okay, we'll have to talk about that some because I need to get caught up to date on that.
No problem. Easy to Google. I'll show you.
This is a interesting story. It's hard for me to really figure out how, when patients call me and they say they can't get their cholesterol down, they can't take any statin drugs because they're so allergic to them. They can't get their cholesterol under 180, 190, or 200. But no number has ever caused heart disease. What causes heart disease is what is passing through your lips every day that is going to absolutely destroy the capacity of your endothelial cells to make an adequate quantity of the life jacket of your blood vessel, which is your nitric oxide level. And as you begin decade after decade eating the horrible Western diet, and as your level of nitric oxide falls and falls, you start making these plaques when you're 12 years old, you make more when you're in teenage, not enough for your events, and now you're into your 40s, you're still eating the same way, and you've got enough plaque that you have this disease. But we found that when we got patients to totally stop any food morsels through their lips that were going to injure their endothelium, not only does it stop injuring, it's the endothelium, but the endothelium begins to recover, and it makes enough nitric oxide that your disease is halted. And often you can get evidence of disease reversal. And I just would sort of feel, I would so much rather have everybody begin to eat correctly rather than to have everybody be on a drug, because these drugs do have side effects. And we have any number of patients who simply cannot take any of these statin drugs. They are in no way precluded from enjoying the benefits of whole food plant-based nutrition when they do it correctly. There's a fascinating study that just came out in the American Journal of Cardiology, which we get automatically when we become a member. And it had to do with these 1,200 people in Spain. They had absolutely normal risk factors across the board, 1,200, okay? Then they carefully studied them. They did carotid ultrasound, calcium score of the heart, ultrasound in the infrarenal aorta, ultrasound in the iliofemoral region, 49% of those people have cardiovascular disease. So, you know, here they are getting all the right numbers that we would want them to have, and half of them have already started forming this disease. There's another study that has been so fascinating to me, which is called CANTOS. And I mentioned it to you today when I spoke earlier this morning. And CANTOS was using a very, very powerful anti-immune drug, canakinumab. And the fascinating thing was, in the group that responded and had fewer cardiac events, they did not even budge their LDL cholesterol. So it comes back that inflammation is probably much more powerful than we ever thought before. And guess what is a lot safer and less expensive than canakinumab? Plant-based nutrition. And it's very powerful for lowering cholesterol, and it's very powerful for getting rid of inflammation. And I think that's the way we got to go.
If someone's a 54-year-old male, they are thin, they feel great, and they eat animal products every meal, would you recommend that they be on a statin drug? What are the pros and cons of statin drugs, and do they help prevent deadly heart attacks and strokes?
So, yeah, let's go back to it again. Yeah, and just to talk, showing Dr. Campbell, you just Google the words mortality, statin use, and you'll see that the placebo group lost every trial except one. That was ALHAT. And that's because it was open labeled, and the doctor saw the cholesterol was high, and they put them on statins, so at a high frequency. So every true placebo-controlled trial, you couldn't get it one past an investigational review board. The data is so strong. So where can we really believe them? Because, you know, a lot of us, many of us up here, and probably some in the audience, have a little skepticism when it comes to pharmaceutical sponsored trials where they have a vested interest in the outcome. So there's one trial that didn't have that. It was the TNT trial called Treat to New Targets. It was low-dose Lipitor versus high-dose Lipitor. They weren't going to make them a penny more because they were charging the same for the 10 milligram and the 80 milligram. That was about a 18% decrease in heart attack, stroke, and death in the high dose, okay? Now, the reason to mention it, because I really want to double down on what Dr. Esselstyn is saying, is that, you know, we're giving these drugs expecting that everybody's going to take them, and it's just not true. So in that particular trial, they said, oh, the symptoms, and it's usually muscle soreness, are just not that frequent, and it's not that dose related. It's more like 8% versus 8.5% in the high dose. So you'll be fine. Well, the way you get a low number like that is you do a run-in period, okay? So you ask people will they participate, you give them the drug for 3 weeks, and if they tolerate it, you're enrolled in the trial. If you don't tolerate it, you're out. Well, okay, that actually is done with every trial for toxicity, for safety. You do a run-in period. So it's standard methodology, but you can't use that in your office and say, oh, it's 8%. So being a person who's treating a lot of disease and a lot of people who are refractory to changing their diet, no matter what I do and say, which is a handful, but they're still there. And then people who genetically have so much LDL cholesterol, they've got the xanthomas and the knuckles with the big cholesterol deposits. You need all hands on deck for everyone like that. So we do end up using a lot of statins, and the higher the dose, the lower the event rate. And so there are going to be people who really need them, but it shouldn't be $30 billion. It shouldn't be the majority of Americans, because most of the people can do it with lifestyle. And so we had, you know, somewhat controversial guidelines come out in 2013 where we said we're not just treating the LDL cholesterol anymore, we're going to treat the risk. And so maybe many of you may have the app for your phone for the ACC's risk calculator, and it said, oh, well, we're just going to increase the number of statins used. No, I was actually taking people off, because if they had an LDL greater than 130, I was taught that I was supposed to put them on the drug. But if they have no hypertension, they are not a smoker, you put all of their risk factors in, and they come out 5%, I took them off the statin, okay, and see if they can maintain that. And so we have learned a lot over the years. Statins, I believe, have their rightful place, but if everyone was a thin, walking, everyday vegetarian, we would not be needing this big pharmacopoeia of drugs, including statins. So I would say they're not as dangerous as people say they are. They're not as safe either, as the other side would tell you. They are not necessary for most people, but we've got to get our population a long way educationally in terms of lifestyle for us to be able to decrease their use.
I think that's enough. Do you want us all to talk about it?
No, only if someone has something to say.
I think Kim said it all.
Okay,
Can I
sure.
have to make a comment here. This is kind of fun. I like the debate, but it's, in a sense, Dr. Williams just showed me some evidence supporting what he said before that I tended not to agree with, that mortality is reduced. I see this data here. It's quite impressive. What study was that and where?
So I literally just did put in statin reduction mortality. I just put those into Google and went to images so you can see Kaplan-Meier plots. Those are the little survival plots. And you see a massive number of them. There's just trial after trial after trial of a reduction, including the one that I talked about, low dose versus high dose. You have, and a lot of people are still using, I hate to do trade names, but Zocor. When that lost every single trial. And so you have 2 of them that are really powerful and 5 that are not. And using the ones that are weaker have a weaker outcome. And so they're all 20%. And every population, probably one of the most insightful ones was another one that looked at just taking your diabetic. It's interesting that if you look at the Nurses' Health Study, and I'll talk about this one tomorrow, and talk about what causes nurses to die. And they've got all of the risk factors, and they collect all this data. We would have thought that smoking would be the #1 thing. Smoking came in 3rd. #1 was getting older, okay? #2 was diabetes. And so this epidemic of obesity, which creates diabetes, particularly central obesity, is really running havoc. Well, believe it or not, we have drugs that can take a diabetic who's otherwise asymptomatic and no other risk factors and lower the cardiac event rate by 22%, and that's just a low-dose Lipitor. Now again, I would say they're great drugs. I'm not a fan of them because it's unnecessary. The diabetes is accumulating because of the central obesity, and if you get that to go away, you don't need the drugs, you don't need insulin and all those things. They're actually increasing plaque by the moment, and the folks are really at high risk, and we have to actually do this as a population, not just with drugs. So anyway, so I'm agreeing with you for the wrong reason. There is data, but we still shouldn't be using them. We shouldn't have to. Okay.
Just one more follow-up on that. I do recall 2 things. One, I thought that I've read that statins are connected with increase in diabetes, and I also remember a Business Week article like 12 years ago saying with all this statins, they are lowering cholesterol, but they're almost not even lowering deaths at all, which is the real goal. So, and that was...
So that was... We're live? And so that's the part. The second part is what we were just talking about. Just Google those 3 words and you'll see all these, just massive numbers of studies where people have spent a lot of time and effort. A lot of it is pharmaceutical industry, but they still have shown that heart attack, stroke, and death. Probably the one where we were more shocked recently, if I had to pick out a highlight, was the HOPE-3 trial, where you might have heard of the poly pill, where they put a statin in with a antihypertensive, and they gave it to people with 1 risk factor, and then they jumbled all the data up. So you had sort of 4 quadrant. You had the fake pill, completely fake. You had the fake statin, the fake antihypertensive, and the people who were on both. And then you could divide it into 2 halves and in 2 ways and see what the results were. There was a lot of good data, and it did what you thought it would do. It would decrease events. But the shocker was the effect of statins on stroke in the people who were randomized to not get the antihypertensive and their blood pressure was averaging 140, 150. If they were on a statin, they could tolerate that blood pressure with almost a 50% reduction in strokes. So they really have a role. I'm just, again, saying I'm not against them. I'm against the fact that we have to use them because it really shouldn't exist.
Were any of those studies done with plant-based nutrition? No. So, yeah, that way, yeah.
An entire industry that's totally unnecessary. That you've been saying this for years. I mean, and so we have unnecessary diseases being treated with unnecessary medicines, but they do work. You know, I mean, seatbelts work. I mean, if you have all automated cars and there are no mistakes, you don't need seatbelts. But right now, we do need them.
Can I add a comment here about your reference to the poly pill?
Yes.
I find that one of the most troublesome words I've seen in recent years.
Yeah.
You know, we're talking about poly pills. My
Yeah.
God, you know, if one doesn't work, one drug doesn't work, let's try 2, 3, whatever.
Right.
Is what I mean. You know, in a general sense, for the public to even discuss the possibility that we might be working toward developing poly pills,
Right.
troubles me, because that really sort of conveys the message. You know, okay, we can live by drugs. We're going to have one sooner or later.
Right.
And instead of talking about the real thing that matters.
Can I double down on that? So the whole idea of the poly pill is that's something you would not do in the United States. That is, people expect individualized care. You don't say, oh, you've got a risk factor, we're going to throw this pill at you. But in third world countries, that shouldn't even have high blood pressure and high cholesterol and diabetes. They're getting it because they're westernizing. They're having our franchises on their corners, and they're incentivized to do it because it's cheap food. They are ruining their lifestyle, losing their agrarian society, and doing less exercise, sitting in a chair. And so now they can't afford the drug costs that we have here. And so you just take this large population of people who are all of a sudden cardiovascular disease is #1, and you throw poly pills at them, and they actually work. But again, you know, I can say it. This goes on. I'm probably going to say it 50 times. These are totally unnecessary. You shouldn't need a poly pill. But does it work? Yeah, it does.